One of the main focuses of this project was to reach the target for ARV initiation. So to get everyone who needs to be on ARVs initiated on treatment every month. In the 2 sub-districts that we worked in, we virtually had to double or even triple the number of patients accessing care. And that has sustained way beyond the end of the project, which is now over 6 months ago. So we strengthened the systems enough to sustain that. And then sustaining the methodology, I think the people who are trained in it will probably use it all their lives, but really to sustain it, what we need is buy-in from provincial government. The whole model is extremely innovative. It's a very, very different way of working. You know, usually in these hierarchies of care, people get told what to do. You know, there's some sort of difficulty around that. So it's a whole different way of, first of all, expecting there to be barriers to care. So you're looking at the whole implementation process totally differently. And then you engaging the knowledge about the systems from the front line.
There were a lot of unnecessary obstacles, you know, that were before the patients before, that we didn't see as obstacles, but as we, you know, started working with the project, we saw them as, look, we could improve on these things. And I can tell you now that we've improved on basically every area of service to the patients. We're able to cut down the waiting period, patient waiting period by 50%.
High burden communities are obviously devastated by this epidemic. And the clinics which serve the communities, the primary care clinics, can be overwhelmed, frankly, because people who move from HIV towards AIDS are going to get TB, opportunistic infections. They're going to be really ill and need a lot of treatment and support.
In the past, what we used to get was patients come to us when CD4 counts were already very low. And that meant that we were seeing very sick patients. And that took a lot of our time, the patient's time, and a lot of government resources. But what we did was to work with the day hospital to start a wellness clinic. And with the wellness clinic, we were able to actually bridge that gap, where patients who are positive stay on the wellness clinic, even though they do not yet, you know, qualify to start on ARVs.
It's also getting people, frontline healthcare clinicians, to be involved with the systems, working in the teams together, and then working across facilities, not just to put patients into treatment, but to start looking at how we're doing this, how are our systems actually impacting on care.